So we have already covered epidemiology, burden of illness, about the virus. We have had modules, and we also discussed about the pathogenesis of COVID. And the other day we discussed about the diagnostic tests, including the lab diagnosis, the chemical diagnosis or biochemical diagnosis of various markers. And of course, also we looked at the CT changes related to COVID, the radiology of COVID also. We looked at today, we have to look at the case definition and how we trace these people, including the clinic. So we just have had a look at the COVID tests, and we are going to look at the clinical features, the grading of the disease, the triage, the oximetry role, and of course the comorbidities and additional information we are going to look at. Again, to bring you back these two words, quarantine and isolation, we have covered this earlier, but again I am recapitulating for you. Quarantine is when the when the person is not sick at all. The normal individuals who are just had the exposure and they didn't have the disease as yet. Don't confuse. Don't say I have quarantined a case. Don't say that. Case is isolation, and non-case are asymptomatic individuals who are having the exposure are the quarantine people. The quarantine and isolation don't go together. They are two separate things actually. So this also we looked at the incubation period 0 to 7 days, and maximum is 14 days. And so far, so many people are tested till 1st October. This also we looked at. Now, WHO, what is a suspect case? According to WHO latest definition, what is a suspect case? Acute onset of fever and cough are three of the following: fever, cough, and general weakness, fatigue, headache, myalgia, sore throat, coryza, dyspnea, anorexia, nausea, vomiting, diarrhea, altered sleep. So many mics are fluttering and making noise. Purna Chandra, why don't you? Very disturbing, sir. If the mic is open, you people have to take care of your mics. Except Dr. Sudhir's mic, no other mic need to be open. Okay. The case definition is whether somebody has got fever and cough. That's straight away an indication. Or somebody has got any three of the following that are listed there, and one of the following within the 14 days of symptoms of onset. Suppose I have cold, I don't have any exposure at all, I have not gone out anywhere, I have not contacted anybody with COVID. The chances of disease are very unlikely, isn't it? Residing or working in an area with a high level of the high risk of transmission. That is one thing. We are all are in that zone now. Residing or traveling to, of course, this is not tenable now. Working in a healthcare setting. If you are working in a healthcare setting, if you have any one of these symptoms, then that is okay. Or patients with severe acute respiratory illness. Sorry, it is called the syndrome of acute respiratory illness. Acute respiratory infection with history of fever or measured fever of more than 38 degrees and a cough onset within the last 20 days requiring hospitalization. So, what are the people who are suspected? Those who had symptoms, particularly fever, cough, other things like headache, myalgia, sore throat, coryza, dyspnea, anorexia, nausea, vomiting, diarrhea, and altered mental status. Having resided in an area of good quick transmission like what we are, or visit, of course, to a country where disease is there, or you are in a healthcare setting, or you are admitted with respiratory illness in the hospital. Until proved otherwise, it is COVID now. So we have to test those people. One thing that is glaringly missing in this list of WHO is the anosmia, or loss of sense of smell, or loss and also taste. These are very important features because we do see that almost 95% of the patients who are COVID positive and who have the disease, they are complaining of anosmia, and some are having ageusia or loss of taste also. Yesterday I was in another meeting, somebody was asking what is the cause of anosmia. The cause of anosmia is the olfactory epithelium is affected. So this is the rhinovirus, as you all know, respiratory virus. It affects the nose as well as the respiratory tree. The target cell is ACE2. that is the angiotensin converting enzyme 2 cell is there, that is the target cell. This target cell is maximum populated in the respiratory tract, particularly in the alveolar lining and also in the olfactory area. So olfactory epithelial involvement is the cause for anosmia. Now, probable case definition, that is a suspect case definition, almost the same. Suspect case with chest imaging showing findings of CVD, say COVID-19. So they have a chest X-ray or chest CT which is showing findings suggestive of COVID. What are these findings? We have seen yesterday: the ground glass appearance, peripheral, bilateral, multilobar involvement, or there will be crazy paving sign, or the bronchiectasis, or a vascular dilatation, or subpleural thickening, any one or more of them, particularly if the score is more than 5 out of 25. 5 out of, I also showed you how to grade it, 5 out of 25, 10 out of 25 the other day. Recent onset of loss of smell or taste is also a very important probable case in the absence of other identifiable causes. Suppose there is acute coryza, common cold, naturally the smell will be less. In the absence of other causes, somebody has got loss of smell or taste, it is important. Unexplained death in an adult with respiratory distress who was a contact of probable or confirmed case, epidemiologically linked to a cluster within the at least one confirmed case. That is, of course, also a COVID probable case. Contact of a probable or confirmed case or epidemiological zone to a cluster with at least one confirmed case is also a probable case, which means almost very simple. Anybody who is having upper respiratory symptoms and also cough and loss of smell, who is in a zone of transmission like what we are, is a probable case. Now, we need to differentiate COVID mimics. What are COVID mimics? First question is, do you have fever? If the answer is yes, more likely to be COVID. If the answer is no and if they only have runny nose, unlikely to be COVID. This has been demonstrated in studies, not just like that. So common cold and the runny nose, sneezing runny nose may be due to allergic rhinitis also. For example, 3 weeks back, one of our relatives had dusted the whole house for cleaning purpose and he developed runny nose and didn't have any fever, cough. In 2 days with antihistaminics, the runny nose stopped and COVID test was negative. So this is to say that person who does not have fever, who has other reason to suspect allergic rhinitis, particularly itchy eyes and itchy nose, and if that is there, then mostly allergic rhinitis. If there is no itching, there may be other sorts of runny nose with sneezing may be there. The other thing is, are you having fever? Next question is, do you experience shortness of breath? If the answer is no, again, maybe other flus, other influenza, other sort of respiratory viral infections. If there is breathlessness, the chances of having COVID with cough, fatigue, weakness, exhaustion are also added. Then it becomes more towards the COVID. Now, IDSC, that is the Infectious Disease Society of America, SARS-CoV-2 nucleic acid testing, we have seen this slide. Highly suspected people, low suspected people. Highly suspected, non-hospitalized, hospitalized. You do the test. If the test is positive, of course, they are in the case category. If it is negative, repeat the testing for all of them. Suppose there is a low suspicion of COVID symptoms and then the test is negative. You don't have to repeat the test. Somebody who does not have respiratory symptoms, no fever, no loss of smell, and he is a contact in the family, is tested negative, unlikely to be COVID positive again. Now, this is where we are triaging the algorithm, Algorithm for COVID-19 testing algorithm. From that itself, we are triaging. There is what is called the rapid antigen test, also called the rapid RAT test. This is 15 minutes. You will know the result. What they do is they take a nasopharyngeal swab, and that swab is they put in a diluent, and then they move the swab. They mix the swab in that solution, and all the secretions, viral particles are into the solution, and the solution with a dropper, 1 or 2 drops are taken and put on the card, and the card has to be read in 15 minutes to 30 minutes. One line is control, 2 lines are positive. So if that is positive, there is no more confirmatory test is required. Straight away it is reported to the ICMR as a true positive, and he is called as a COVID case and triaged as per his clinical status. Supposing that test is negative, then what I do? The other day what happened was, in our lower flat, somebody had fever. So that we all had a doubt whether we had COVID. Then we did a rapid test. If the rapid antigen test is negative, we all had a negative test. And then we didn't have any symptoms. If we don't have any symptoms, rapid test is negative, it is negative. And the person who had fever in the lower flat, we tested RT-PCR because they had symptoms, even in spite of the rapid test being negative, and that also turned out to be negative. Probably the fever is some other fever. So how do I go about? A person has respiratory symptoms or COVID-like symptoms, do a rapid test. Why do I do that? Why don't I do RT-PCR directly? RT-PCR is time consuming, not available always. Rapid test is readily available now in all over the country. Now it's available. Biosensor, a company called SD Biosensor, is the most accepted rapid test. And that rapid test, if it is negative, then what will happen? It could be a false negative or it could be a true negative. How do I know? If the patient is asymptomatic, we take it as a true negative and declare it as negative. If the patient is negative but still has symptoms like fever, cough, sore throat, then you do an RT-PCR. And if that is negative, of course they are non-COVID disease. If that is positive, they are positive. Versus somebody whose rapid test itself is positive, there is no need to do the expensive 2.5 thousand or 3,000 rupees RT-PCR. Straight away the person is classified as COVID. This is a point of care test. ICMR has approved and no doctor's prescription is required. Likewise, we are going to get salivary test, we are going to get sensor test. Yesterday, Reliance has announced a test which they are saying that it will be possible within 15 minutes with this RC Reliance test also. All these things are empowering the patients, empowering the public, empowering the doctors too for the diagnosis. Then, how do I triage? So I have got a positive patient. Who is a positive patient? Who is an RT-PCR positive? Or who is a NAT positive, or a RAT positive. So who is a test positive either by RT-PCR or by RAT positive, rapid antigen test, or who has a strong evidence of CT evidence of disease with symptoms. So these are the ones who are test positive. Patients who are RT-PCR positive, patients who are RAT positive, patients who are scan positive but test negative. All these three are considered as test positive. Then the immediate question is, should I admit the patient to the hospital or should I offer home quarantine? Eligibility for home isolation. Quarantine is only for people who are negative. Home isolation. HI is home isolation. Are they eligible for home isolation or they should be admitted? How do I decide? The healthcare worker or the doctor who is treating the patient has to assess the case for preference for home isolation. So here the question is, you have to be guided by the clinical criteria. What are they? Non-communicable diseases, comorbidities. Means somebody is non-hypertensive, somebody is a liver disease patient, somebody is a cancer patient, somebody is a HIV, somebody is a diabetic patient. Anyone has a known comorbidities for the disease, or somebody who is above 65. Or if one or the two conditions are satisfying, even though they don't have severe symptoms, they have to be admitted. There is no possibility of home isolation for these people. In addition to that, people who are in the desaturation, no? Oxygen saturation getting less, who are becoming sick, and the monitoring is required for them for worsening of the disease, they are required to be admitted. So you understand, who are eligible for home isolation. Home isolation are people who are test positive. Please mute your microphones, all of you. Those who enter now, you have to make sure that you mute the microphones. You can't be opening them. So those who are test positive or those who are strong CT suggestive of X-ray with symptoms, they are the people who are cases. They have to be First, assist by the doctor or healthcare worker for eligibility for home isolation. If the home isolation eligibility is they don't have comorbidities, their age is less than 65, oxygen saturation is good, there is no dyspnea, and such a patient can be offered home isolation, provided they have the facility to keep the patient away from the rest of the family members. There are many people who are impoverished and who will not have the facility to have more than one room, or they may not have facility to isolate the patient separately. Many people in the below poverty line, they are residing in single room tenements. And where is the question of home isolation for them? They cannot be separated from the rest of the family. Likewise, there will be single person will be residing, an old parent or a person who is employed and working and staying in an apartment. They don't have anyone to look after there. They cannot be offered home isolation. These are the two conditions. Feasibility of monitoring at home is not possible. Now today, corporate hospitals are offering home isolation packages. You pay around some amount of money, 3,000 or 5,000 for 10 days. They will be monitoring the patient over the video and also looking at the various data like oximetry, pulse, dyspnea and other things, and help them to come to a hospital whenever it is required. These are called the home isolation packages. Now, the disease can be of three types: acute, symptomatic, asymptomatic illness or mild illness. Asymptomatic, no symptoms at all, only test is positive, and mild illness is ILI, that is influenza-like illness. The second category is who have acute respiratory pneumonia, that is SARI type of pneumonia, syndrome of acute respiratory inflammation, that is SARI pneumonia. They are also not eligible. And of course, people who have desaturated, not severe diseases, they are not eligible for home isolation. So from among those who are asymptomatic or mild, suitable for home isolation, not suitable for home isolation, depending upon the criteria which we have discussed. And if they are suitable for home isolation, of course, you do the home isolation under supervision. If they are not suitable, then you have to admit them to COVID care center. Government of India has designated them into three types of categories. One is the CCC, COVID Care Center, dedicated COVID healthcare facility, and dedicated COVID hospital, DHC. We will see a little about them in the coming slides. So this slide we have seen yesterday. These are the people who had a symptomatic course. These are the people who had asymptomatic course. They are exposed here. There is latent infection and then symptomatic infection. The antigen test will be positive amplification test here, and slowly it dwindles. The antibody IgM starts appearing later around 2 weeks, and that also comes down. Then the IgM starts and it goes on increasing. So this is what we have seen. This is the incubation period stage, this is the symptomatic stage, this is the convulsion stage. The other course is somebody may not suffer the disease, they're asymptomatic, they just have the incubation period, not much of symptoms are there, they get into convalescence and recover. These are the two types of patients. Now, this lists all the symptoms. The headache is another common symptom, cough, sore throat, shortness of breath, nausea, vomiting, diarrhea. I had quite a good number of patients who complained of loose motions. And then we tested for the COVID later on when they had fever. After the 2 days of loose motions, then they were COVID positive. Of course, they recovered. People who started with diarrhea are generally recovering well than those who are starting with the respiratory symptoms. This is the experience over the globe, all over the globe. Fatigue, muscle weakness and body aches are there, but these are not like dengue fever. These are not severe symptoms. The main symptoms are the congestion of the nose, loss of smell of this one, cough, sore throat, and shortness of breath. And sometimes there is what is called the happy hypoxia. What is this happy hypoxia? All of you should know. Patient will not have any symptoms of desaturation. They will not be having any breathlessness. They are very comfortable at rest because most of the people are not doing any exercise. There is no demand on the heart or the lungs to challenge it for any desaturation experience. But they are desaturating in the body and the oxygen levels are 80, 88, 85 like that. But still the symptoms of desaturation or hypoxia are not felt by the patient. Such people are called the happy hypoxia, which is quite dangerous, just like hypoglycemia unawareness. Supposing patient is having hypoglycemia, he doesn't have the sympathetic symptoms like tachycardia, sweating, flushing and all that. It is very dangerous. They are suddenly going to see serious hypoglycemia. Likewise, these people are also having desaturation or hypoglycemia, but they are not having the symptoms. Such patients, the prognosis is generally bad because they go to the hospital very late until the symptoms are severe and the desaturation is very severe enough. That is why we have to be aware of the happy hypoxia. How do I know that? Everybody who is tested positive must be monitored for the pulse oximetry. It is a very valuable tool, very sensitive tool as well as a specific tool. Sensitive means it will, if it is 97, 98, we are very sure the saturation is good. Specific means if it is 90, 89, we know that it is desaturated. It's both sensitive and specific with a marginal variation of 1 to 2%. Here, I would like to tell you one more test to unearth the hypoxia. That is called the 6-minute walk test. What do? I take the pulse oximetry, record the oximetry values in heart rate, and ask the patient to walk on the level and at home only for about 6 minutes, plain walking. All of us can do the test also. They do not see our respiratory and cardiopulmonary functioning. But in COVID patients, this is highly useful because if they have a lung involvement which is going to desaturate, we will definitely know that these patients are going to desaturate by seeing a drop in the oximetry. So drop of 3% or increase in the heart rate of more than 20 after 6 minutes of walking is indicative that the patient might desaturate very soon. So you have to do the 6-minute walk test. It is contraindicated if somebody is breathless, somebody is aged 70 plus, somebody has got other contraindications for level walking even. Suppose somebody is heart failure patient. We don't want to precipitate symptoms, but generally, normally everybody will be able to tolerate. And one other cause for the 6-minute walk positive test would be anemia. Somebody is severely anemic, the 6-minute walk test would be positive. Beware of the other conditions with hemoglobinemia, anemia. These are the other conditions which will produce this happy hypoxia as well as a positive 6-minute test. So with this, I'm going on to the next slide. You can see here, it is a beautiful way of representing the symptoms, different symptoms, starting with cough on this side and the conjunctivitis on the other side. When the red is there, you can see it is not there. Majority of the patient did not experience. For example, all these symptoms beyond this are almost not there. Whereas the ones in blue are the symptoms which are mostly there. Percent of people who have symptoms, 60% had cough, 65 had fever, and around 60 had shortness of breath, fatigue, confusion, cough, with sputum, diarrhea. And remember here another thing, it is not a non-productive cough. Mostly here it is a dry cough, unlike in other respiratory conditions, where by the time the cough and fever start, it is usually productive. Non-productive cough is also another important thing. Nilima, you people should be careful with your mics. Okay, muscle ache, chest pain, headache, wheeze, abdominal pain, these are coming down in the frequency, whereas these are the very frequent symptoms. These are the less frequent symptoms. As I told you, this first time I am seeing a diagram to put up all the symptoms in one show, see which are common, which are late. An excellent way of representing. I thought I should show you this diagram. Next one. Another thing is variation in clinical course and outcomes. People who had fever, how did they do? And people who had a cough, how many days they had? And then dyspnea when it started, ICU admission when, in which day they started, symptomatic, systemic corticosteroids when admitted, when was the test positive, non-survivors and survivors. They have compared survivors and non-survivors. Look here, cough, fever, dyspnea are almost the same. But then the ICU admission rates are much. Invasive ventilation is there in these people, and systemic corticosteroid administration was continued late. Sepsis, ARDS, acute cardiac injury, secondary infection, and there are the various things that are causing them the mortality. So this is also a comparative chart of survivors versus non-survivors in terms of the various incubation period, prodromal phase, pneumonia phase, immunologic phase. The prodromal phase is around 1 to 7 days. Incubation may be around 7 to 10 days, 3 to 10 days. Pneumonia phase 1 without desaturation, phase 2 with desaturation, and shock, ARDS, multi-organ, immunological cytokine storm are here. Now, the symptomatic but no lung involvement, no pneumonia, only ILI, pneumonia without desaturation, pneumonia with desaturation, clinically ill patient. This is the natural history of the patient. Not everyone who is here asymptomatic will go to critically ill. Most of them, they can recover here or here. Some of them, they have pneumonia around 10 to 15%, around 5% to 8% are in hypoxia. Out of them, the death rates in our community, we know in India, is around 1.6 to 1.7. Initially, it was 2.7, 2.8 mortality rate in the community. But here, nowadays, it is only 1.6 mortality. Case fatality rate in the hospital depends upon what type of cases you take. Suppose yours is a tertiary care hospital and you take high-end cases like Apollo Hospital or Manipal Hospital. High-end patients who are really sick are referred here, and then the case fatality rate of the hospital is going to be very high. Versus another institution which is treating only mild and moderate disease, their fatalities may be few and far between. They may not have any fatality at all. So you cannot compare one facility with another, one hospital with another in terms of case fatality rate, because the type of patient that they are drawing will decide the outcome of the individual. Another thing is males are more affected in this particular pandemic, particularly in terms of severity and also mortality. And that is, we have also explained the pathogenic reasons for the male predominance in this particular pandemic. Suppose somebody in your family gets symptoms, what do you do? They have symptoms of COVID, record the temperature, respiratory rate, oxygen saturation, give paracetamol 2 or 3 times a day, vitamin C twice a day, take a COVID test. Interventions like HUKs, ivermectin, azithromycin, I have put in gray color because earlier they were being used. Today they have found that they are not going to be very useful. Do you have any other ills? Like, family member is positive, do you have contact history positive, do you attended a gathering like a marriage or a grave pravesham, or do you work in a healthcare? That question gives a probable answer to what will be the test report. Report awaited, unless proved it is negative, treat them as COVID patients. Home isolation and separate room, wear medical mask, use disposables, monitor the symptoms thrice a day, watch for fever, breathlessness, measure saturation. It should be at least 494 or more. Test report positive positive report is given. Nothing to panic. Continue the advice. More fluids. How much? 4 liters of fluid, unless you are a renal patient. Nutritious food, fruits, vegetables. Avoid non-veg and other spicy food. Contact your hospital or government facility. You may need home isolation, or you may be a case to get admitted in DCC or DCHC or DCH. This is what we have to do. What are the symptoms? Once again, cough, dry cough, particularly fever, and then the cold may be there. And then hypothermia is also important. Low body temperature is also an impending disaster. So sore throat, throat pain, loss of smell, taste, weakness, diarrhea, I told you. Serious symptoms are exhaustion, altered sensorium, and breathlessness. This is for people who are non-medical people, or somebody who is becoming sick in a family. What to do immediately? This slide you can share with them, and they will be able to say all contacts and family members of a test positive must be quarantined and take a COVID test. If they're positive, they have to be isolated. Guidelines for management of COVID cases. SOP means what? Standard operating protocols. Standard operating protocols are prepared as a part of the guideline. If you're in a community or housing society of 300, 400 houses, or even more, there will be a standard protocol for them. The municipalities would have given them the guidelines. Where a cluster of people are residing in an apartment or in a cluster of houses, there are standard operating protocols to ensure optimal utilization of the available resources, to ensure appropriate care for all COVID patients, to ensure that hospital beds are available to more moderate and severe cases. Not everybody with mild disease is admitted. By this home isolation and SOPs, to see that mild disease is managed at home. That is two-way. One, the transmission is reduced. Two, the beds are rather not occupied by the milder cases. So there are 3 levels of COVID centers now: CCC, DHC, DCHC, and DCH. What are they? We have to see. So COVID care center is DCC. This is a triage of positive cases based on symptoms and presence of risk factors. Okay, somebody is 60 plus and has no, non-communicable disease. He is already a case to be admitted. Where do you admit? Dedicated COVID care center is the CCC. DCHC is dedicated COVID care health center. DCH is the dedicated COVID hospital. DCC or home isolation is for symptomatically mild or very mild or asymptomatic illness who are tested positive, who are less than 60 and have no comorbidities, and where there is a facility to isolate the patient separately. In the absence of that, they will be in the COVID care center. The next one is DCHC, symptomatically moderate, low risk patients, of course, age less than 60, NACD and no NCDs, and these people have what is called the mild level of desaturation, and these DCHCs have got the facility for oxygen also. Then you have also got the DCH, dedicated COVID hospitals, and these are like your GEMS hospital where there are dedicated COVID hospitals, symptomatically severe patients, they are admitted there. Now, what is our role? Above all, whoever is tested positive, don't get panic, because this is a respiratory illness. 85 to 90% of them pass the infection without any danger for their life. Around 10% of people will get into some moderate to severe disease. They may need hospitalization, out of which 5% may need hospitalization, and only around 3 to 4% need intubation. But once the patient is intubated, the outcome is not really very favorable in many studies all over the world. So people who are well, to avoid becoming infected, people who are sick, to avoid infecting others and to recover from illness, people who are caring for the sick like healthcare workers, to protect themselves and other family members of themselves. And doctor or a nurse or a healthcare worker should not give to the family, and at the end they should not feel, I have deceived my family, I have undone my family's benefits by taking COVID into the family. This is very important for healthcare workers. All of you be aware that we are the potential sources for our family to get ourselves and also to transmit. Maybe we may be asymptomatic, but there is an old parent, father or mother or grandmother, and if you go there and give it to them, and that's it, they will get it. So clinical course of fever by requirement of the ICU, as you can see here, the blue line and the red line. Blue line is the non-ICU care, and the blue line is the ICU care, and red line is the non-ICU care. In 9 days, the people in non-ICU are recovering. ICU people are even recovering up to 31 days or even more. So the number of patients who are in the ICU around 10, 15, 20, even 31 days. But majority of the people who are non-ICU, by about 2 weeks, they should be back home. And then, those with fever, those with PCR positivity also, that means who are tested positive, this is the ICU care, this is the non-ICU care. Again, around by 21 days, the virus excretion is negative. Usually you have to test after 21 days and confirm that they're negative so that they can mix with the other family members of the community when they can go. So clinical presentation may vary by age and sex. We all know headache, loss of smell, nasal obstruction, asthenia, cough. Different studies in different countries are showing the different proportions of those people. And then loss of smell are 70%, obstruction of the nose 67, like that. We are able to see all these things. Now, let us see the NIH guidelines defining COVID-19 severity spectrum. So this is NIH's National Institute of Health USA, same as our recommendations in India also. Milder illness, moderate illness, severe illness, critical illness. What is asymptomatic illness? Positive for the test, but no symptoms. These are the ones who usually recover. They don't get into complications. Milder illness, varied symptoms, no shortness of breath or dyspnea, no desaturation. Moderate is SpO2 is more than 94, lower respiratory disease evidenced by the clinical assessment or the CT. Severe, SpO2 is coming down, and then PaO2 by FiO2 is less than 300 still, and then the respiratory rate is 30 or more, lung infiltrates are more than 50%. This is called the severe illness. Critical, of course, they are in hypoxemic respiratory failure. Earlier we did class for the PGs on high respiratory failure, type 1 respiratory failure, type 2 respiratory failure. This is not hypercarbic respiratory failure. This is hypoxemic respiratory failure, septic shock and MOD, multi-organ dysfunction. Severity in the mainland China, they had mild cases 80%, severe 13%, critical 4.7, no data in our 0.6. So the severity, critical severity is decided by the age, cardiovascular disease, diabetes, chronic respiratory disease, hypertension and cancer. Those are the persons who had severe illness. Comorbidity status at hospital admission among COVID patients associated with the COVID positivity in New York City, you can see more than one comorbidity, 87%, one comorbidity is 6.3, none 6.1. That means those who are admitted, they had comorbidities. What is the commonest comorbidity? Hypertension. Hypertension all over the world, we have realized that people with hypertension and obesity are the ones who have more admissions than any other disease. Of course, diabetes also is important. Hypertension, obesity, diabetes appear to be forerunners in the comorbidities. Usually admitted patients, they have at least more than one comorbidity or at least one comorbidity in some, none only 0.1% in the New York City study. Radiographic and lab abnormalities by disease status, and among COVID-19 patients in mainland China, you can see that radiographic abnormalities, chest radiograph, chest CT, white cell count, lymphocytes, platelets, CRP, D-dimer, lactate dehydrogenase, liver enzymes, all of them in the non-severe disease is this pattern and severe disease is this pattern. You can see the severity of the disease can be assessed by all these parameters, including the radiological parameters. Host factors predicting COVID-19 severity. Can I predict a particular patient is going to be severe or less severe? One thing is the comorbidity. Second thing is the age. And third thing is the lymphopenia early in the disease. Lymphopenia early in the disease. And also today we have studies to show hypolipidemia. That is, their LDL and triglycerides are lower. They are in for a severe disease. These are simple markers. Do a lipid parameter, do lymphocyte count, and look at the age. You will be able to prognosticate whether the patient will move into higher category. Likewise, people who had IL-6, interleukin-6 measurement, whoever had the interleukin-6 measurement done, and those patients, interleukin elevated 3 or more times the upper normal limits, they fared worse compared to the others. So what are the prognostic factors? Number one, age more than 60 or 65, and then lymphopenia early in the onset of the disease. 3, they have other comorbidities like hypertension, obesity, obstructive sleep apnea, chronic lung disease, and diabetes. People who are smokers and chronic lung disease, they also had a worse prognosis. And people who had hypolipidemia particularly, and LDH also. LDH is a good marker of pulmonary function. And interleukin-6 values also are predictive of severity of the disease. Now we know the other day we saw COVID once it is infected, it could be low viral titer, mild illness, isolation, home isolation, supportive care, normal immune response, they recover no cytokine excess. Or some of them, they may have activation of the macrophages and neutrophils, they produce cytokines, and the cytokines may be mild and low and then recover, or the cytokine storm may occur. They may show all these cytokine changes, and the chances of recovery towards this side, or they may progress down also. Suppose they have high cytokines, or there is cytokine storm, or they have a high viral titer, and then here the severity of the illness is more. They have, in spite of various interventions and ICU care, lung injury, septic shock, organ failure, coagulopathy, ultimately fatal outcome are the rule. Here, the virus titer, there are several reports I wanted to bring to your notice. What is called the CT, cycle replication time. What is cycle replication time? Supposing I show the sample to the machine, PCR machine, if it detects in the first cycle itself, that means the virus load is more. Suppose that I ask it to multiply it by 2 times and then look at it, that is cycle 2. Then 3 times it amplifies, nucleic acid amplification test. 3 times, 4 times, 5 times, up to 25 times the amplification the machine does it. Amplification is like enlarging, zooming your picture. So it is trying to make more copies of whatever little particle is there in the test, And in spite of 25 times amplification, if it is not seen, it means it is negative. So cycle replication time lower is indicative of severe viral load. Cycle replication time, somebody is not detected until 20 or 24 or 23 cycles, the viral load is less. Then does it have any correlation with the severity of the disease, with the severity, with the outcome, with the admissions, with the hypoxia? Studies have shown that cycle replication time has got no bearing on the clinical outcomes or clinical course or the final outcome. But then why to do it? This is earlier they are being done the report like that. You can see the report, they say CT 22, CT 15, CT 5 like that. CT is not, this is the CT scan. It is the cycle replication time. Now WHO and international agencies, ICMR, have clearly concluded CT in the lab CT, that is the cycle replication time, has no value in terms of severity and prognostication. Now, predictors of mortality. Which are the people who are going to die? You see here, less than 50 years, they are surviving. 50 to 59, 60 to 69, 70 to 79, more than 80. Always much better in the younger age, the older age. Look at the females. They are way less than 1. If 1 is the average mortality, female sex is doing better compared to male sex. So chronic cardiac disease, pulmonary disease, kidney disease, diabetes, obesity, neurological disorder, dementia, malignancy, severe liver disease. Among all, the best predictor is the age in terms of negative outcome and the gender in terms of positive outcome. Now, look here, the clinical symptoms, cardinal clinical signs and potential therapies. Severity of the illness starts here, 7 days, 14 days, 21 days and beyond. Viral response phase, this is where the RT-PCR will be positive, stage 1 early infection, and most of them are home isolated. Stage 1A without hypoxemia, pulmonary phase. Pulmonary phase with hypoxemia is 1B, and hyperinflammation, the cytokine storm, coagulopathy and all that ARDS is the stage 3. Here, mild constitutional symptoms, fever may be 99.6, dry cough, diarrhea, headache. Here, shortness of breath, hypoxia. Here, ARDS, syndrome of, SIRS, respiratory shock syndrome, and then cardiac failure. And clinical signs here, lymphopenia, early lymphopenia, increased PT, increased D-dimer, LDH, I told you, and interleukins. These are predictive here. Abnormal chest imaging will start here, transaminases, and then low or normal procalcitonin. Here. But once they get secondary infection, the procalcitonin is a marker of bacterial infection, elevated markers, all the CRP, LDH, IL-6, D-dimer, ferritin, DROP, anti-proBNP, all are elevated in those cases. So treatment wise, you see here, potential therapies, the antivirals, antimalarials, nucleoside analogs, convalescent plasma, immunosuppression, corticosteroids, human immunoglobulin. We're going to discuss the treatment in our next lecture. This is tailoring the treatment as per the stage of the disease. Now, criteria for treatment, the COVID care center, asymptomatic, mild cases are admitted, pulse rate is less than 100, respiratory rate is less than 24. They have other comorbidities, that is why they are admitted. If they don't have it, they are qualifying for home isolation. Here, dedicated COVID health center, DCHC. Here, oxygen is desaturation is occurring. Tachycardia is there, desaturation is occurring. Respiratory rate is increasing. SpO2 is between 90 and 94. They may or may not have comorbidities, but they are admitted here because of the hypoxia. And dedicated ICU bedded hospital, which is called the dedicated COVID hospital, DCH. SpO2 less than 90, tachycardia is more, blood pressure is falling, respiratory rate is more. They have other comorbidities. They have to be treated. These are the triage criteria for the things. So I showed you this laboratory parameters also on the prognosis, lymphopenia, leukocytosis, neutrophilia, and then thrombocytopenia, CRP, procalcitonin for bacterial infection, LDH for pulmonary injury, transaminases for liver, bilirubin for liver injury, creatinine for the kidney injury, cardiac troponins for cardiac injury and tissue injury, low albumin again for the impaired liver function, prolongation of the prothrombin time, and D-dimer, These have to be monitored. How frequently I do it? On 0 day, on the 5th day, and every 5 days. If the patient is in the mild case, you don't have to repeat them after 5 days if they are normal. If he is in the moderate category, A or B of moderate, you have to do them every 4 or 5 days, and then see if they are increasing, then you have to do every 2 days. If they are in the ICU, every 2 days, these have to be monitored. This is the protocol, internationally accepted protocol for monitoring the thing. Immune inflammation and thromboinflammation markers, we have already discussed CBC, ESR, lymphopenia, CRP, ferritin, LDH, CPK, procalcitonin and leukocytosis for bacterial infection, drop test, D-dimer, PTT, fibrinogen for thromboinflammation, hypolipidemia, I told you, low LDL and low TG, severity of the COVID disease is correlated, interleukin 6, cytokine storm once in 5 days, others once in 2 to 3 days. These are the predictors of thrombosis, as we have already seen the D-dimer, fibrinogen, CRP, ESR and ferritin earlier we discussed. Guidelines for management of COVID cases, SOPs are prepared as per the guideline. 3 levels of COVID centers already done. COVID care center is a center where there is no oxygen facility, but there is facility to monitor, keep the patient separate in a room and also monitor the pulse oximetry and the heart rate. And there is somebody, healthcare worker is there who is going to 24/7, somebody is available, and basic life support and ambulance is also available in a COVID care center. Whereas dedicated COVID healthcare center, they have a beds with oxygen supply, and there are separate exit and entry areas, and of course this is being monitored by a doctor, only under a allopathic doctor. Whereas here, there is no allopathic doctor, there could be Ayush doctors or paramedical people can manage. Here, these patients are not desaturating. They only have the milder disease and they can be here. But of course, they have the pulse oximetry in place, and also there is the ambulance facility. Whereas here, they must have an ambulance facility to transport to other centers, and these are linked to DCHC. If the patient is becoming better, they are transferred to CCC. The becoming worse, they are transferred to DCH. DCH is COVID care hospital, offers comprehensive care for COVID, run by private sector as well as government sector. In some hospitals, medical care hospitals, medical colleges, they have government beds as well as private beds. I'm sure in the GEMS also there will be 2 categories. The poor category where they are treated free of cost, and also there will be category where paid category also is there. That is possible in college hospitals, but exclusive private hospitals, there are no free category there, but there also, in some hospitals, they are reserving a few beds for their poor category patients. Also, here the advantage is that fully equipped ICUs are there, independent ICU beds with assured oxygen support, ventilators also are there, and oxygen therapy will be covered by our other specialist of anesthesia. He will tell you various levels of oxygen therapies. At that time, we will also discuss those things. So comorbidities already we have discussed, hypertension being the leader, obesity, lung disease, cardiovascular disease, diabetes, cancer, renal disease, immunocompromised patient, chronic liver disease, neurological other disease. Increasing age is a important parameter. In female sex, it's protective, smoking, hemoglobinopathies, first prognosis, fatality in healthy subjects also we are seeing. Young individuals without any comorbidities, they are coming. One, because of happy hypoxia. Second thing is they don't care the symptoms in the first week. They only detect the disease in the second or third week, and when the disease is worsening. Above all, the reaction of the system to the virus is the important thing. This is biology. This is not, mathematics, where 2 + 2 is equal to always 4. This is not history, where Taj Mahal is built by Shah Jahan. It is always the same. Whereas in biology, it is not like that. So each individual, innate immunity, the various factors, the age, other responses, the ability to cope, psychological and physical strength of the patient, all have a bearing on the outcome. Here again, O group appears to have a better outcome. From studies, we know people with O group did better compared to others. Is what we cannot change anyway, but don't be under the complaints, I am O group man, I will not get severe disease or disease at all. That is not correct. But only thing is saying that O group appears to do better. Criteria for discontinuation of when do I say patient is okay, we can go home? Symptom-based strategy, test-based strategy. 3 days of resolution of fever without antibiotic, 3 days without symptoms of fever, without any dolo or anything, and improvement in the respiratory symptoms, or 10 days of symptoms have elapsed. So, for example, I tell you, a patient had COVID positive and he had no fever after the 3rd day, and then he has no respiratory symptoms, but still he is not negative because 10 days have not passed. So, first of all, 10 days should have passed, they should have respiratory symptoms, and they should have fever for 3 days at least. This is called the symptom-based strategy. Test-based strategy, resolution of fever without antibiotic and improvement of respiratory symptoms. 2 negative molecular assays, not antibodies, my dear. 2 negative RT-PCR or rat test assays using consecutive respiratory specimens collected 24 hours apart. This is a test-based strategy. Why this is important? I wanted to declare somebody as non-infective for 2 reasons. 1, to reassure the patient that he is cured. 2, for him to be able to interact with the other family members. For example, the one member is suffering, he is removed to the 1st floor, he is staying there. When he has to come down and mix with the family, that question has to be answered, isn't it? For that reason, these are important. Likewise, when he should be sent out from the hospital, DCC, DHC, or CC, when he has to go home, these are the criteria, test-based and symptom-based. And you see, seasonal flu and COVID. The RO number for seasonal flu is 1.3. What is R0? R0 is the ability to reproduce in another individual. If a person is there, 100,000 people are there. If the R0 is 1.3, he will give it to 1,300 people. If the R0 is 2 or 2.5, he will give it to 2,000 or 2,000 people. 1,000 people will become 2,000 or 2,500 is R0 of 2.5. To start with, we had R0 of 2.8. Today, most of the states are registering an R0 nearing 1. The epidemic will end when the R0 comes below 1. That is, 1,000 people are producing 900. 900 are producing another 800, 810. Again, 0.9 of them like that, it is dwindling. Whereas if it is more than 1,000 producing 1,110, they are producing 1,200, 1,400. That is an increasing trend. Again, incubation period here is 1 to 4 days in flu. Here it could be as long as 14 days. Hospitalization rate in flu, common influenza is 2%. Here hospitalization rate are around 19%. 80% are home, 19 to 20% are case fatality, 0.1 or less, and it is 1 to 3.4. In our country, it started at 2.4. Today, we have got a case fatality rate is much lower. Actually, we have to say it is a mortality rate. Case fatality rate is hospital fatality rate. I told you, it depends upon the type of patients you take in. If you take in severe patients, your mortality will be on the higher side. If you take on a milder illness, your mortality will be lower. Okay. Now, the guidelines, general guidelines here is, if you don't invite COVID, I won't catch you. If you don't invite me, I won't come to you. That is, do not read or view negative news. Do not depend on WhatsApp messages and forward messages. They say this particular thing is working. Somebody will come out and say this kashayam is working. You can't try that. These are untested things. All the same, evaluated literature has to be carefully understood. Do not forward COVID messages. Check info from authentic sources like WHO, IDSA, NIH, Ministry of Health, ICMR, like that. I have shown you the links also in the first presentation. Recovery is the rule for many. Not to think too much of severe illness and its implications. What if I get severe illness? What will happen to my property? What will happen to my car? Who will take this? And all the where they will bury me. All these things are, not the things to be thought of now. Have a robust health insurance always. Now plan. There are top-up plans available. All of you can opt for top-up health insurance plan. In case we require higher care, it will be in the tune of 20 lakhs, 30 lakhs, 40 lakhs. We may not be able to afford from our pocket, and have adequate financial planning of whatever resources you have. These are the general guidelines. Estimated proportion of COVID cases. This is the age distribution. And you see higher the age, the more are the COVID cases. These are now hospitalizations. And likewise, COVID, you can see this is Lancet publication. 8.2% in 50 to 59 versus 4.3 in 40 to 49-year-olds. So the age is an important factor. You see here deaths of COVID here. Critical patients, severe patients, milder cases. If this is the square of milder cases in that study, this is the square of the severe cases. This is the square of the critical cases. This is the square of the deaths. In general, if you have a pneumonia, any pneumonia for that matter, even bacterial pneumonia, community-acquired pneumonia, the mortality even in the best hospitals is 5%. If you get admitted, the mortality is 5%. COVID pneumonia is no different from the other pneumonias in terms of the mortality. But the ability to transmit to others and get more cases and overwhelm the community is there. That is why we are careful not to transmit it. Okay, you see here the age groups. This is another way of representing a simple dot less than 0 to 9, 0.01% versus 18% above 80. These are various ways of depicting the data. External links, I've shown you the imaging sciences later on. The treatment protocols for COVID-19 will continue on 8th October, coming Thursday. Thank you all for a patient listening. If you have any questions, I'm prepared to be here for some more time and answer.
Okay. You are telling a resolution of based on the symptom strategy. The resolution, when do you discharge the patient, that is fine. But in this test-based strategy, what happens is the improvement in the respiratory symptoms are there, and the COVID test comes negative. That means you are discharging the patient, you are telling.
Okay, even before 10 days.
So what test molecular resistance, does it include the...
again, the same strategy, RAT, RAT if it is positive, is still positive. If RAT is negative, you do a RT-PCR.
Sir, the problem here is, what happens is, after some days, RAT can become negative. Okay, you're coming to the IgM positive phase and the IgG where the immune reaction is so much more. Correct. And with treatment, symptoms decrease. You will think that symptoms have decreased and the test is negative, and many are sending off the patient. So what happens is, the treatment, they don't take the treatment afterwards when they are discharged and things. Maybe a little bit they'll take.
Treatment after your discharge is their fault. You have to.
Yeah, fault in the sense. But whatever is given in the hospital, the oxygen and the related medication, the injectable medications are not given. So that can lead on to many what is happening is, we are going to the hospital and getting treatment is showing improvement. After coming off again, it's worsening and things. So what happens is, these hospital people cleverly what they can show is, it's come negative. Nobody is doing the IgM and IgG, whether it's positive. IgG is not a worry. IgM positive, that suggests that immune reaction is more that time. So if you think that the test becomes negative and IgM is still there, and if you discharge the patient, still it can become bad also. That is one thing which has not been concentrated. I felt like that, sir.
I'll tell you your problem. I'll try to address. See,
okay.
Let us say a patient is admitted into our hospital and he had no fever for 3 days. After that, no dolo is given, no fever was there.
That is fine.
Let me complete. So, no respiratory symptoms are there, cough, no shortness of breath, oximetry is 94, 96, 98, 6-minute walk test is negative, not desaturating, and he has thrown 2 tests negative. Means what? His virus excretion is not there. Means he is fit to be at home. He is no more deserving any care in the hospital. He can be continued the medicine. Nobody says you stop medicine. Doing an antibody test will only show you whether he had COVID or not. It will not tell you whether he will become better or not. No antibody test prognosticates the patient. It only tells whether the antibody response is good or not. Some people mount it early, some people mount it a little late. What antibody I would need to do? I have to do only IgM. IgM is not a neutralizing antibody. IgM is only an immediate phase antibody. It is not a memory antibody. Suppose IgM is high, we can't say this fellow is better off than compared to another fellow who did not have IgM. Because IgM is not protective antibody. Only IgM antibody.
Yeah, but
takes around 4 to 6 weeks to come. Nobody is going to keep the patient until that time. Okay.
Sir, but if IgM is positive, that suggests that severe immune reaction is still taking place.
No, sir, that is normal immune response, not severe immune response. IgM positive means patient has mounted a good immune response. That means he is good. IgM positivity does not cytokine storm. IgM positivity is an immune response to the virus itself. And that doesn't mean the patient has mild, moderate or severe with IgM. We can't categorize.
So that means with IgM positive, if the interleukin IL-6 is negative, that means they are safe to go.
That's what we have to monitor other parameters also.
Other parameters also.
All the other parameters, IgM positive, RT-PCR negative, no symptoms, no fever. I am very safe.
Okay.
Suppose interleukin is negative.
Okay. I mean
negative. All are normal. Then why should I keep him in the hospital?
Correct. All those things are because they have taken only 1 or 2 aspects and telling that you can be discharged means many don't do the other things.
This is the WHO slide. I copy it. But in the center there is one thing: improvement in respiratory symptoms. You can add improvement in all the test parameters also. You add there. That's all.
Yes.
As a clinician, you can individualize the guideline, and as a clinician, you would like to make sure the fellow is not in the immune storm or in the cytokine storm or in the hypercoagulable state when you discharge. And another thing,
that has to be done.
when we are discharging this patient, anticoagulants must be continued for 21 days. Maybe oral. I'm not asking you to give injection, but maybe oral. When we come to the treatment part, we will dilate on that. And steroid also, we have to make it into oral steroid, methylprednisolone or solumetrol or something. You can change over and send them home. With dexamethasone in the hospital, oral prednisolone at home. They have to continue.
Okay.
So now the question is solved. IgM, remember IgM is only says the patient has developed an antibody response. It is not a protective antibody. We cannot grade a patient as mild, moderate or severe or cured based on IgM. What are the parameters? Symptoms without antipyretic, respiratory symptoms, oximetry, blood markers. Of course,
those are not mentioned.
RT-PCR negative.
Okay.
Or 10 days have elapsed. With all these things, 10 days have gone, no need to test again. What I was saying is, if you don't want to test second time and your resources are constrained, don't go on testing everybody whom you are going to discharge. 10 days are over and all the things are negative, parameters are returning normal, assume he is normal. That's what they're saying.
Okay.
The general poorer countries like us, symptom-based strategy is for resource-constrained categories. Test-based strategy is for private hospitals and countries where they can afford testing any number of times because the party is third-party payer there.